Could you please explain the difference between a PE peri arrest and just a plain old cardiac arrest?
Okay, so what I mean from that question, or what I interpret from that question, is what is the difference between a peri-arrest and an arrest? Does that sound fair?
Yeah.
So a peri-arrest is when the patient looks like they're about to arrest. So they've usually still got, well, they have still got a pulse, they're often still breathing, but they're often fairly comatose and their blood pressure is not a lot. So these patients look ghastly, but they have an output, they are breathing, and they do have a heartbeat with an output which is usually low. But if I don't do anything quickly, they will arrest, and what I mean by that is their heart will stop and their breathing will stop. And then potentially that's an even more difficult situation to manage. So when I see someone with peri-arrest, I've got the opportunity, if you like, to quickly try and work out what's going on here to prevent them from arresting. And that's my sole aim. And in hospital situations, we would call a peri-arrest wherever it is, and we get the same team come, because that's what we want. We want an experienced team of anaesthetists, cardiologists, medical doctors, nurses to come and give us a hand really quickly to stabilise the patient's airway, to stabilise the patient's heartbeat and blood pressure really quickly, to try and reverse all those things before we get to the point where the heart says, I've had enough, I'm stopping. Because then we've got to do CPR, we've then got to resuscitate the patient, we've got to maybe shock the patient, maybe do X, Y and Z. And that's as far as the illness can go, where when the patient arrests, it can't get much worse. And so with peri-arrest, you have a window of opportunity to prevent arrest, is what I would say. And your chances of surviving, if you can keep a heartbeat and keep breathing, is better than if it stops. And so you want to reverse those situations as quickly and as effectively as you can. Now, sometimes no matter what we do, unfortunately, patients deteriorate. But very often, if we can identify what the problem is, which is usually people are very dehydrated or are bleeding or have a major problem, if we can reverse that quickly, we can often prevent the peri-arrest becoming full-blown cardiac arrest.
Okay. Is there any substance to believe that sleep apnea is linked to sudden cardiac arrest?
It's interesting, isn't it? So, if you're a Star Wars fan, probably yes, I think. Is that where this is coming from?
Well, no idea.
Yeah, so, I think what there is data upon is that I don't think if you have, this is my personal view, I'm not an expert on sleep apnea, but if you have sleep apnea, there is certainly a lot of data to support that if you have heart failure, you do less well. And the reason for that is you come in with more hospital admissions and you have more, and you die earlier. So we know that sleep apnea in the setting of heart failure is associated with a worse outcome. But let's just look at, let's say a 70-year-old gentleman has sleep apnea. Is he at more risk of sudden cardiac death than a 70-year-old man without sleep apnea? I think we would be hard pushed to show an absolute causal relationship. So again, I think it's one of those things that probably fits into one of the risk factors for, but I think it's quite far down the list. But certainly in association with heart failure, sleep apnea is associated with worse outcomes.
Is it unusual to have cardiac arrest with Takotsubo?
Takotsubo, yeah. So Takotsubo is a fascinating cardiomyopathy, and I think let's just, so people who don't know what it is, I'll explain. So it's from an observation that the heart, for a variety of reasons, can go into meltdown, where a normally functioning heart literally pumps 20% of its blood volume out on the click of a finger, literally. Patients usually present with terrible, terrible chest pain and present like heart attacks. And then what we do is we look at their coronary arteries, usually very quickly, and their coronary arteries are normal. So we cannot blame the coronary arteries for causing their chest pain. When we look at their heart pump, it's gone from pumping completely normally 1 minute to pumping 20% of the blood out the next minute. And of course, you can imagine that has bad effects upon breathing, upon fluid, and these patients. So just to answer the question very directly, is it common to have an arrest after a Takotsubo? Absolutely yes, because you go from having a normal heart to a completely abnormal pumping heart incredibly quickly. We can't fix arteries to make it better. And what's quite incredible about this cardiomyopathy is that when we look at these patients 4 to 6 weeks down the line, their heart has completely recovered, and we don't understand. We have no idea why it works. And so some patients get it because it's called the broken heart syndrome, when there's a terrible episode of stress in the family. Maybe a loved one dies and you're at the funeral, you suddenly get chest pain. We see this time and time. I mean, the last one I saw was a patient running late for an aeroplane at Stansted Airport and had a cardiac arrest. Exactly that. Came into the cardiac centre with a cardiac arrest from Stansted. They did a great job, flew him to us, flew her to us. It's generally women as a rule. In fact, I've never seen a male have Takotsubo, and they're anything between middle-aged to elderly, so it tends to be between the age of 40 and 75, I would say. But the reason why we're picking so much of it up is because we're taking pictures of people's coronary arteries so often and so quickly nowadays. So if you come into our heart centre with chest pain, you will get an angiogram often within 10 minutes. And that's good, because then we know what we're dealing with or what we're not dealing with, and we've got to think again. And so again, 10 years ago, when we didn't take pictures of arteries very often, there was loads of this about, but we just didn't know how to diagnose it. Not only that, but MRI is a really good tool at looking at the heart muscle, and we know that it normalises at 4 to 6 weeks. So I bring these patients, I treat them like heart attacks to a point, in that I give them ACE inhibitors and beta blockers, which are good for heart muscle function. But I do not give them aspirin and clopidogrel, or the blood thinners, because they're not needed, because there's not an artery problem. And then I send all these patients for an MRI, and I bring them back at 6 weeks with the MRI, and generally it's all gone away. So this is a very serious condition. It's more common because we just diagnose it more commonly, because we're doing the tests more commonly, and I see probably almost one a week. I don't know, it's much more common than we think. Yeah.
So is there going to be a lot more research in that area?
There is a reasonable amount going on, yes, but it's all relatively observational, as you can imagine, because you see there's sort of studies writing up 100 of these patients in a series, but and we are getting better understanding of it.
So I've got to ask this question because I'm one of them, and there's probably about 30% of our group are idiopathic. Could we all be resultant of that?
No, I don't think so, because to get the diagnosis, you have to have normal coronaries with a normal LV. So Takatsubus have a very obvious pattern of a pump that doesn't work very well. Right. So probably, maybe when you and other idiopathic patients came in, you look at your heart muscle, it looks normal. It's too good for you to have had a VF arrest. Does that make sense? These will look terrible. These ventricles will be 20% ventricles. Okay. And what's then different about them is that their coronaries are normal, they're terrible ventricles, and then they get better at 4 to 6 weeks. That is the evolution. Whereas idiopathics have normal coronaries, normal LV. Why would a normal LV run into a problem? And then it does, and you haven't got this that then gets better. So I think the fact is it's that the ventricle at the presentation is the key determinant here.
Mm-hmm. What does the ventricle look like, Tom?
Yeah, so the reason why it's called Takotsubo is that when it was first described in Japan, it basically looks like an octopus, and so the pump. There we are, good. The pump is like a sort of V, and it pumps like this, and we see this on the LV-gram when we do an angiogram. And what happens with Takotsubo is that the V bit balloons out, and only the bottom bit pumps. So the top bit pumps, and the bottom bit sort of balloons out, and it does look like an octopus. And so that's how it comes. But we also see reverse Takatsubos where it's round the other way. So the bottom line is, again, I'm sad to say, we don't fully understand it. We're getting better understanding, and the more that we make these types of diagnosis, the more we send them for MRI early and late, the more we will understand these syndromes. But this is not straightforward.
My son had a diagnosis of vasovagal and bradycardia the same day as his cardiac arrest. Are the two related? I hope I pronounced that
correctly.
So
no, you didn't. Terrible. Vasovagal. So what vasovagal means in a young person is that all of us are constantly controlling our heart rate and blood pressure. And what we're trying to do is we're trying to keep our brain adequately oxygenated with a decent cardiac output. And so again, when we stand up, our arteries and our veins all squeeze in our legs to maintain the blood pressure going up to our brain, and we have a little increase in our heart rate just to keep that blood going up when we're losing our cardiac output a little bit. So we want to keep the brain supplied with blood. And what I always say to people is that the brain perfusion is protected at all odds. And so when you lose consciousness with a lack of blood supply to your brain, something bad is going on, because the brain protects itself from loss of consciousness very aggressively. So would I say that and so for people who don't know what a vasovagal is, a vasovagal is like when you get out of the shower quickly and your heart rate goes down and your blood pressure goes down, where actually what you want to do is you want your heart rate to go up a little bit and your blood pressure to go up a little bit, so that you maintain oxygenation and perfusion to your brain. And so the bradycardia in young people can happen. Young people and fit people often have a resting slow heartbeat. But I would say to you that yes, I think it would be too unlikely that they're not related. I guess the honest answer is, unless you were monitoring his heart at the time of the vasovagal, then you will never know. But I would suggest to you probably they are related. But it also depends who made the diagnosis of vasovagal / bradycardia. So we often can attract incorrect diagnoses made by other non-specialist doctors. So if it truly was a vasovagal bradycardia, I would suggest to you it is related.
Okay, you briefly mentioned about how the brain protects itself when someone's in cardiac arrest.
Yes.
If someone has a cardiac arrest and they are down for a reasonable amount of time, the question is, can it lower your IQ?
Yes. Well, I think the honest answer is, and again I say this to everybody who's had a cardiac arrest, the brain has had, by definition, a lack of perfusion for some time. Whether that's a few seconds, whether it's a few minutes, whether it's 30 minutes of decreased perfusion.
Could you just say what perfusion is?
Yeah, all I mean by that is that let's imagine you have a cardiac arrest and your heart stops beating and it's unwitnessed for 5 minutes. Now, theoretically, your brain will have had no blood supply, no new oxygen, nothing for 5 minutes. When you then get, hopefully, chest compressions and CPR, then we know that you may get a blood pressure of maybe 80 millimetres of mercury. We want 120, but you might get 80 or 90. You'll get something half decent. I think the answer to the question, if I'm going to be brutally simplistic, is that it can only lower your IQ. It can only kill neurons. It cannot make it better. And I think that's the only fair thing to say. Now, whether we are, again, capable with our tools of identifying how that's going to affect a patient. There's not many patients where we go, oh, you're going to have a cardiac arrest in the next couple of weeks, so if I do the IQ quickly now and then we'll follow you up, we can't do studies like that. It's impossible. Mm-hmm. And so the only thing we could do is you could take a huge cohort of patients, of which your group is probably the biggest cohort, and you could say, what do you think the person's IQ was, and then test it, but it would be completely prone to bias. So I think it's an almost impossible thing to do, but I think at the same time, I think lacking of blood supply to the brain, which kills neurons, can only be a bad thing, and that's why we've got to do everything that we can do to make that injury to the brain minimal. That's why we're interested in hospital, or pre-hospital we're interested in CPR, because that's really important. Early defibrillation, really important. Coming to a place like the Cardiac Centre at Basildon, which has an expertise in this to deal with people and to deal with people's hearts and brains. Cooling people, I know I've gone on about this last time, but we are massive believers in the protection of the brain by cooling the patient. And so I think that it's about doing all of those things well and then rehabilitating the patient afterwards to give the patient the best brain outcome, if you will. And I think that's what it's all about.
And sort of following on from that, has any research been conducted recently on recovery from sudden cardiac arrest, particularly in relation to broader recovery, the cognitive, emotional, etc., as well as the physical?
Yes. My group are doing, I hope, a considerable amount in this area, where we have just set up our care after resuscitation clinic, doing exactly that, purely looking at the psychological effects and trying to understand the early problems patients have following a cardiac arrest and their carers, and then trying to point them in the right direction, whether it's counselling, whether it's cognitive therapy, whether it's neuropsychologists, whether it's psychiatrists, and we have about a 25% psychiatry referral rate currently for our patients. So the answer is yes, but there's not as much as there should be. There is not as much out there in any geography to support patients who have had cardiac arrest or their families. We are about to start, there's a huge trial starting in October in the UK called the Temperature Management Trial 2, the second trial, has 1,800 patients and follows patients out to 5 years, collecting all of the data that you just talked about. And so it's not going to be just our centre, there are 8 centres in the UK. We will probably be the biggest collector of data, but it's also in the Nordic countries, up in Sweden and Denmark, and we'll collect 1,800 patients, exactly what you described, for 5 years. So I think in the not too distant future, we will have a much better understanding of the effects as this question describes.
That's excellent. It's sort of a question for either of you. It sort of follows on from about the recovery aspect. Many people try to get fitter. So if you're looking to exercise with an ICD fitted, is it worth investing in a heart rate monitor or a Fitbit? Or simply should you just go with the feel of your heart? And if you're using a heart rate monitor, what rate should be taken as a maximum? And if using feel, how would you describe the maximum effort?
Tricky question. I think, I have a smartwatch, records my sleep, my heart rate, it only adds to how I live. I think if you're already thinking about a Fitbit, personally, you're already on the first step to doing some exercise, which I said earlier is only going to benefit patients. The devices, from a device point of view, the devices aren't affected by Fitbits and heart rate monitors, because they generally look just beneath the skin to see what the heart rate is. So there's not an issue from that point of view. I think if someone like Tom advises you not to do exercise, or your GP, then you take that into consideration. And then the whole what rates to exercise to and what you should do is a tricky question. I know at gyms they have cardiac rehab classes. There's cardiac rehab classes at hospitals which help out and help patients exercise. They use heart rate monitors, and in all fairness, you do have to go with what you feel. I always say to patients, you know when you're being lazy, you know when you're doing too much, so you need to get yourself in the middle, and only you can judge that, because I don't know what's vigorous activity to you. To someone, walking a mile is nothing, but to someone else, walking a mile is a big achievement. And so you just have to judge it yourself and gauge what you think is right. Don't go crazy, but don't be at that point where you think, I'm being a little bit lazy.
Is it worth getting professional help, like personal trainers and those sort of people involved in your rehabilitation?
Personal trainers cost a lot of money.
Or going to your cardiac centre and see if they have a rehab. And
there are cardiac rehab courses available, generally for patients that have had a heart attack, granted. But the gyms, they will help prescribe an exercise routine for someone. They won't let you go mad. And I think if you're in there with the right people and you're starting to exercise, you're already on the right track. And then people will know their bodies. They should know their resistance, in my opinion. And obviously that will change. I think with the medication that patients are given, it generally restricts patients from exercising to really fast heart rates. So someone necessarily who is able to exercise and get their heart rate to 180 beats per minute, who then has a beta blocker added to their medication, probably isn't going to get up to 180 beats per minute, and that's when we know it's abnormal. So difficult. I'm not sure if you can add anything else to that.
I think in answer to sort of where the question I think is trying to go is, I would do, the bottom line is we just want patients to get back to the best quality of life that they can, and I think they want to do that with confidence. And so some people will gain huge confidence from knowing their heart rate was 80 this minute, 120 in the exercise and back to 80, and they all feel very, very happy. The other thing, the flip side, is some people don't really want to know. They've got an ICD in place, that's their insurance policy, probably will never fire, probably will never do anything, but it's sitting there watching for the day that if it does, it will. Does that make sense? And so I think that every human being who gets a device is potentially different, and I think that you've got to decide what sort of person you are and what's the best way of getting you back to full fitness. Are you a worrier that's going to be reassured by seeing something, or are you just better just not knowing and just doing it responsibly and getting on with it? Does that make sense? And I see patients on both sides. Some say, I love it, I love having my heart rate monitor, it reassures me, I know where I am and I'm very happy. And likewise, I see other patients who go, do you know what, I just want to do it sensibly, but you know, I'll go stir crazy if I look at it every 5 minutes. And so I think it's got to be very patient specific. There's no right and wrong, and do whatever makes the patient feel good.
I think the other thing to add to that though is that if you do get a heart rate monitor, don't look at it every 5 minutes like Tom mentions, because you will go crazy.
You can drive it up yourself about 30, but just by getting stressed and looking at it.
Exactly.
Yeah.
It's just that.
So look at the I agree. Look at the 2 hours you were walking and
just
talking.
use it as a guide,
As a tool.
you know, just a reference every now and then. I wouldn't say that if you're exercising you think, oh, my heart rate should be 110 beats per minute, but it's 100 beats per minute. That's not a significant difference.
The other thing we should say is while your defibrillator CRT will give you a perfect heart rate monitoring, the Fitbits and all other technologies have errors.
Yeah.
And they can't manage arrhythmia, they can't manage AF, they can't manage
Topics.
a variety of other conditions because their algorithms are so simple. So again, I wouldn't get hung up on a cheap Fitbit that costs you 65 quid when you've got a £5,000 ICD that's doing it a hell of a lot more elegantly. So just know the limitations and be sensible, I would say.
Don't overly worry yourself if you see the odd.
Definitely don't overly worry.
Definitely.
And then, look, funny, next time you're at your follow-up, ask about what your heart rates look like at particular times when we were exercising. And I'm sure if that reassures you and gets you back to full fitness, people will be very happy to support it.
Okay. You mentioned about going mad earlier.